So continuing the story of chronic pain, we talked about the four mechanisms that produce pain, and now we're going to talk about sites in the body that generate neuropathic pain using those four mechanisms. So neuropathic pain can arise from abnormal activity in the periphery, such as nerve compression, as in carpal tunnel syndrome, or ulnar compression at the elbow, and the central nervous system in response to deafferentation, and in the dorsal horn of the spinal cord. So those can be sites that are generating neuropathic pain. So with peripheral generation of neuropathic pain, injury or disease of the peripheral nerves results in sensory abnormalities. So sometimes if a nerve is completely resected, either on purpose or accidentally during a surgery or an injury, it results in a lack of sensation from that nerve's receptive field. That partial damage can result in allodynia and sensations similar to an electric shock, so people can get that electric sensation. A lot of times after total knee replacement, people, well, pretty much everybody tells me that they're numb on one side of the incision, and that's because of peripheral nerve resection. As it starts to regenerate, they often get those sensations of electric shock, and that's it's not neuropathic pain at that point, but it's pretty weird, and I hear that a lot from people. So peripheral abnormalities causing neuropathic pain include development of epiphasic transmission that occurs in demyelinated regions. So you've got the damaged peripheral nerve, an example being like nerve compression in carpal tunnel syndrome, median nerve compression. You get demyelination from that compression, and so then you're getting basically that electrical short. The nerve's not firing right, and it causes that neuropathic pain. Apoptotic foci in an injured nerve that occur at a nerve stump or in areas of myelin damage, that's where we have those extra receptors that are sensitive to temperature or mechanical sensations being built up in the areas of myelin damage or in damaged dorsal root ganglion somas. And so we've got nerves now that are generating responses to things that they never generated before. We've got those areas of the injured nerve that are now creating action potentials outside of input from the receptor. So when you get deafferentation, which is where you lose the peripheral input, it can be complete or partial. So neurons in the central nervous system can become abnormally active when the peripheral sensory information is completely absent. This is one thing I learned in the medical neuroscience class. Even though I knew this in the back of my mind, but one thing that really came out to me was how a lot of nervous system research is done on animals to begin with. And I sort of have issues with animal research, but you can't, well, you could take like a, I can't think of an animal that they used. I think they used, for one of the things, they used ferrets or something like that. So you can take a ferret and you can intentionally deafferenate them, avulse dorsal roots, and see what happens. But you can't do that to a human being. I mean, I still have a problem with doing it with a ferret, but I'm just saying, a lot of primary research is done in the nervous system. I don't know where I'm going with this. Oh, I know where I'm going. The avulsion of the dorsal roots, that's a lot of times how they found that out, is through animal studies. And then through accidental deafferentation. So that deafferentation causes someone to feel burning pain in the area of sensory loss. So even though you lose sensory input, the central nervous system responds by creating burning pain. So it's kind of not fair, really, but there you go. Phantom limb pain or phantom pain, they've sort of separated into two areas. Phantom limb sensation refers to individuals who've had a limb amputated, but experience sensations that seem to originate from the missing limb. So a family friend of mine was in a car accident and ended up getting a below-knee amputation on one leg. He had very good recovery, and he got fitted with a prosthesis, and you'd see him walking around, you'd never know that he had a prosthetic limb. But he said he would get home from work, and his feet would hurt, and it would be both feet. So the sensations, the same sensations seem to originate from the missing limb. Obviously his prosthetic foot didn't hurt, but it felt like both his feet hurt. So, I thought that was kind of interesting. A phantom sensation that is painful is called phantom pain. So phantom limb sensation is pretty common to individuals with an amputation. Phantom pain is a little more rare than phantom limb sensation. So you can also have pain in the residual limb, which is not phantom pain. And it's treated differently. So treatment for residual limb pain, you're actually treating sort of normal pain sensations in the residual limb. And phantom pain, you're going to be using things more like graded motor imagery and mirror therapy and things like that, because you can't address pain in a limb that's not there with pain medications or with regular treatments for pain. So you have to use other means in order to do it. So central pain is caused by a lesion of the central nervous system, and it's usually localized to the area of the body deafferented by the lesion. So that would be someone who has MS or has had a CVA or something like that, and so part of their central nervous system got deafferented because of the lesion. So that's basically deafferented. You can think of it as separate from its afferent input. So neuropathic central pain is usually burning, shooting, aching, freezing, or tingling pain. So when you hear descriptions like that, shooting, freezing, tingling, those are usually neurological in origin. Spinal cord injury can result in central pain, and they think that the thalamus may be the site of pain generation because after a spinal cord injury, the neurons in the ventral posterolateral thalamic nucleus are spontaneously active without input from the spinal cord. MS can result in central pain, and it depends on the location of the lesion. So MS plaques can be anywhere in the central nervous system, and depending on that location, that can result in that central pain. So small fiber neuropathy produces partial deafferentation and central sensitization. Small fiber neuropathy is pretty common. Post-herpetic neuralgia, diabetic neuropathy, and Guillain-Barré syndrome all cause deafferentation pain due to damage to small diameter C fibers. So it seems counterintuitive that lack of input would cause pain, but it actually that lack of input is worse than having input in terms of central generation of pain. Very interesting.